Hello, good evening, and I would like to warmly welcome everyone for the GP. I would say that I'm sure that you would be benefited by today's session. And let me introduce our speaker for today. Our speaker is Dr. Sankha Randenikumara, who is an eminent GP, and I'm sure he doesn't need any introduction to this audience. But as a formality, let me introduce Dr. Sankha. Sankha is a family physician and he has his own practice at Vattala, and he is the regional chair of the Spice Route Young Doctors Movement for South Asia and the chair for Spice Route Sri Lanka, and also the chair for SLMA Young Members Forum, and also the Honorary Secretary of Palliative and End-of-Life Care Task Force at SLMA. And also he is the Assistant Treasurer to the College of General Practitioners of Sri Lanka. So we are very much privileged to have Dr. Sankha to share his clinical experience. Over to you, Sankha.
Thank you, Aruni, for that kind introduction. Let me share the screen. I recently got, among many other interesting cases, I recently got this very important patient who was a usual patient of mine. Okay, can you see the screen?
Yes, Sankha, we can see.
Right. Thank you. Right. Okay. So today I'm going to talk about a special patient and person who is a regular patient of mine, and we have chosen a special topic course for this. You will see why this topic is. Right. This is the story of Mrs. SG, of a 52-year-old female. She actually first came to me on 14th of July last year as a patient. Her main complaint was bilateral long-standing knee joint pain, which was more on her right side, more than the left side. And she had an X-ray, which clearly showed right knee joint space. That was a right-sided X-ray, right knee joint space narrowing and osteophytes, which was hinting for osteoarthritis. And when I looked into her records, she had some BP records. For last 2 months, the previous 2 months, there was recorded continuous high blood pressure, and always the systolic blood pressure was more than 150, and she was not started on any treatment by that time. And when I went into the family history, her father had diabetes, and she was telling about some sort of cancer related to testes, but she was not sure about any other say origin or whatever, but she knew that it was in her testes as well. And mother had a some sort of a coronary cardiovascular event, CVA, and her social history. Her husband was in Seychelles in hotel industry. She had 2 children, a daughter who was 23 years and son who was 12 years. And they are actually a financially sound family and very friendly. So when I examined her, she was not pale, and her weight was 82 kilograms and the height was 1.49 meters, and which came into a BMI of 40, obese patient. And the BP at that time was 158 by 90 millimeters mercury, and pulse rate was 88 beats per minute, which was regular, and there was no murmurs. But when I examined the knee joints, bilateral knee joints had crepitus, confirming the diagnosis of osteoarthritis. And actually, initially I advised on her diet. I advised on a low salt diet, and also I drew and explained this healthy plate, which should include less starch and oil. I wanted her to reduce her weight. The target I gave was 8 kilograms in next 6 months. And also I taught her some exercises for knee joint. Usually there are a few, 2 or 3 exercises I train the patient. So those were also taught to her. And I gave her enalapril 5 milligrams nocte. And this there's a tablet called capsule called Jointies, which has functional keratin, collagen, hydrolysate, vitamin D, etc. Which actually, from my experience, I have seen it responds well to knee pain. So I gave it as well, and also I gave paracetamol, codeine, SOS. So with that, I asked her to come in 2 weeks time. And by that time, blood pressure was 142 by 82, which has reduced. I also asked her to bring some investigations, which were fasting blood sugar, lipid profile, and serum creatinine. All were normal. And I asked her to come in another 2 months. And in last September, she came with less knee pain, and she had no much complaints at that time. And the blood pressure has gone down further, 136 by 80. And importantly, weight has reduced to 79 kilograms. So within that 2.5 months, she has lost 3 kilograms, which was really good. And I encouraged her, and got down in another 2 months. And there was no complaint at all about the knee joint. Blood pressure was 124, and she had lost 8 kilograms within that 5 months, which was very good. And I was really happy. And I also I commended her achievement, and I asked her to come in another 3 months because blood pressure was normal. She has considerably well. She has worked on her weight. So I wanted her to come in another 3 months. So in last March, 2021 March, this year's March, she came. Now, she actually came for her usual follow-up, but the main complaint, the reason for encounter was not the usual follow-up visit. She was complaining about diarrhea for 2 months with frequent vomiting. And on questioning, there was no abdominal pain, no bleeding per rectum. And she was telling that there is further weight loss of weight, and no loss of appetite also. On examination, blood pressure was okay. Her body weight has come down to 66. Note that 8 kilograms have been reduced within last 3 months from 74 to 66, which was alarming. And so at this moment, without going further, I would like to ask you, the audience, what would be the reasons for this? With when you consider the history, everything, and this presentation, what would be the reasons for this?
Some endocrine problem like diabetes should be excluded.
Okay,
And also we have to.
But anyway, diabetes was excluded, not excluded, I say, you are correct, but fasting blood sugar was 94 about 6 months back. Just to. Yeah.
And also we have to think of malignancies.
Exactly. Yeah, another one was talking. Please.
Yeah, there's a family history of malignancy, and the history suggestive the weight loss is like, it looks like more than unintentional actually. So because the you have given a target, but this looks like a bit more than the intentional. So it goes very much towards the malignancy, considering the family history and the symptoms as well.
Yeah. Anything else?
And hyperthyroidism also should be considered because she lost weight instead of good appetite.
Sorry, what was that?
Hyperthyroidism should be excluded because she had a good appetite even though she lost the weight.
Okay, great. Anything else?
Some kind of depression also can, because the husband is away and
yes, actually, yes. Yeah, if you remember, she had diarrhea, also vomiting as well, frequent vomiting, right? Okay, and now you would not consider any inflammatory bowel disease, would you?
Definitely, ulcerative colitis and Crohn's disease should be considered.
Yes. A few things about this, but I would come to that about the inflammatory bowel disease. If you go to the ROM for criteria, I think abdominal pain is one of the key features. We'll come to that, but okay, yeah. So with all, what was certain key features hit me as well. One is this over enthusiastic sort of weight loss, and I also remembered, as you told, the family history of malignancy. And so actually what I did was I asked her to review quickly with stools occult blood, because she told there was no bleeding per rectum at all, but I really wanted to see whether there's some sort of a hint for a malignancy, as you told. And stools occult blood was positive. At this point, what do you think I should do? Should have done instead? Okay, I just you can consider these things. Her age was 53 years, more than 50. She's complaining about altered bowel habits with nausea and vomiting for more than 2 months. There's a significant unintentional weight loss, and there's a family history of carcinoma. Even colonic carcinoma, as you told, can have secondaries in testes. And stools occult blood was positive.
Can we do a 2-week, within 2 weeks, a referral for a colonoscopy?
Yes. What any other ideas?
Yes, here the fecal local blood positive, it can be some benign condition related to GI tract or malignancy or inflammatory bowel disease. For that, to exclude, we can do the fecal cul protein to see whether there is any chance of inflammatory bowel disease. At the same time, this patient need to do the endoscopy for the gastroenterologist referral.
Thank you. Yes. Any other ideas quickly? Yes, I can see certain malignancy, IBD, metformin abuse, but she was not on metformin. She is a truthful patient. I'm sure without my knowledge she wouldn't take anything. Colonoscopy, yes. Digital rectal examination and the colonoscopy. Parasitic infection. Okay, thanks. just about the inflammatory bowel disease, as you mentioned that, this is the wrong for criteria for irritable bowel syndrome. So anything else? The abdominal pain is not there, right? And the other things are stools or blood is positive. So with this, so what I did was I referred her to a general surgeon with a special interest in GI surgery for urgent colonoscopy. So this was what I did. Then the surgeon has seen her, and he has given Librax, that is chlordiazepoxide and clidinium bromide, 1 tablet TDS, and domperidone, 10 milligrams CDS. Now this is for symptomatic relief, but he has gone for full blood count, ESR, ultrasound scan abdomen. At this moment, patient was sending me the reports through WhatsApp. So her hemoglobin was 11.6, which is a bit low, and ESR was 38, almost okay, and ultrasound scan abdomen was not significant. By this time, she told me that vomiting has been settled with the drugs, but the diarrhea was continuing. And the surgeon has, as you told, and I was also asked him to, has referred him for, actually he has done a colonoscopy, and this is the colonoscopy report, which has occasional colonic diverticuli with multiple cecal diverticuli. And upper GI endoscopy, as you was all told, was also done, which had only a large hiatus hernia, but no other abnormalities. So what do you think at this moment? Could this be due to diverticular disease?
Yes, possible.
Anyway, the colonoscopy doesn't say that diverticuli were inflamed, but yes. Any other ideas?
Only thing is the weight loss, significant weight loss is not there in diverticular disease.
Exactly, yeah. Significant weight loss is more with inflammatory bowel disease probably, but yeah. But there was no signs of inflammatory IBD or colonic CA at this moment. Any other ideas? So if you go to diverticular disease, or say diverticulosis and diverticulitis, you all know diverticuli are most often found in lower part of the colon, and this is told to be very common after age of 40, but rarely cause problems. And presence of diverticuli is known as diverticulosis, and inflamed diverticuli is known as diverticulitis. And as you told, the symptoms and signs are constant abdominal pain, mostly lower left, can be on right side as well, fever sometimes, nausea and vomiting, altered bowel habits, mostly constipation, less commonly diarrhea. So at this moment, now patient is not coming to me at this moment. I mean, she didn't come, but she was updating me. She was updating me on WhatsApp, and she gave me a few calls as well. She didn't come. Despite of doing this colonoscopy, which is probably more than other screening tests, surgeon has decided to do colorectal cancer screening again, because he was probably not sure or whatever. He he wanted to confirm or so. So he had done colorectal cancer screening. One is stools occult blood with M2PK test. Are you familiar with M2PK test? Any? Can someone tell about that? I have anyway. I have a slide there.
Please explain.
Yeah, this is actually M2PK test. The M2PK stands for pyruvate kinase isoenzyme type M2, which is a key enzyme in tumor metabolism. And this is a screening method, obviously non-invasive, not like colonoscopy, but here it was done after the colonoscopy, and it is known to perform for early detection of colorectal cancer and polyps, probably the precursors of colorectal cancers. There are two methods, like quantitative ELISA, where you will get a quantitative number, and also a rapid test, positive or negative. At this moment, it was a rapid test. Stools are analyzed. It is told that this test does not depend on blood in stools. So even non-bleeding cancers can be identified. But importantly, could be false positive in inflammatory bowel diseases, other inflammatory bowel diseases, inflammatory bowel conditions. For this presentation, I went through some papers, and it was obvious that it is not a sort of a very good method of screening colorectal cancers. There's a very obvious arguments against that as well. But anyway, this was the result. At this time, when I was doing stools occult blood was positive. At this time, stools occult blood was negative, while M2PK test was positive. I don't know what at that time the surgeon was also feeling. Anyway, I was sent this report, right? But at the same time, when the report was seen by the surgeon, do you have any comments at this moment? Sorry, I'm just going through the chat, and one has asked about CEA. Obviously, CEA is not also a very good tumor marker, right? I mean, CEA is not as good as this. So when you read through that, you will understand that it is common to many other cancers and other conditions as well. Any comment at this point? What can the surgeon do? Okay, what surgeon has done was he has gone for a CT scan, abdomen and pelvis. Sorry, it was a non-contrast one with rectally contrast, which also showed uncomplicated, not inflamed, uncomplicated colonic diverticuli and otherwise normal study. And at this moment, after this, now, mind you, the patient wanted to go to the private sector. I gave her the option. There's a well-known teaching hospital nearby. I told the same surgeon is there in the hospital, but you have the pathways bit, because our system has a problems. The pathways bit difficult, not easy as the private sector. You can't meet the surgeon. When I give the referral letter, they should again go to the OPD, blah blah. So it's a bit difficult. But the same surgeon, same clinic you can approach. But she wanted to go to the private sector. All these things were done in the private sector. By this time, she had spent a lot. All these tests, colonoscopy, upper GI, all this, everything was done by herself. So By this time, she called me and told, after all CT, and everything was, CT was also negative. She called me. She told that she had spent a lot on investigation. And still the diarrhea and also nausea is there. And she has got further emaciated. So she has all these concerns. So I told, okay, let's have a chat. Just come to the clinic. So after 3 months, I didn't see her for 3 months, even though she updated me. After 3 months, on I think last June, she came to me. And here only our topic comes. Then her eyes came to rescue me and her, probably. This is my patient. Any idea? Any comments? Yes, you saw that probably. Do you note anything?
Graves' disease.
Okay, yes. So what is this? What are you seeing? You are not seeing Graves' disease. Yes, guys. Do you see any difference in her eyes? When I saw her 3 months back, I could not, I didn't notice this.
There are small squint is there.
Yeah, sorry. What is that?
Mild squint.
Squint. Okay. Okay. Yeah. Can you appreciate the margins of the lids? Yeah, but this is this is not the photo. It's not a photo taken at that moment, right? I recently got it down from the patient. It's recently the same time, the same days. Yeah. So same period, but yeah, actually there was proptosis. This happens not only for, say, it's not only Graves' disease, whatever thyroid eye disease. Let me see the no one talks, but they type thyroid enlargement was not there in the yeah, but it's not very obvious because probably you see it because of this photo's quality. Proptosis is there. Yeah, there's no view from the lateral side situ. This was sent by her. Would have been better, yeah, but I saw proptosis. An eye surgeon would quickly identify it more than us. But anyway, 3 months back, I asked her whether the same thing was there 3 months back. She told no. Probably after 3 months, it came, appeared. Now, sorry. Yes, it's proptosis. And I quickly, with diarrhea, loss of weight, I also appreciated probably this should be hyperthyroidism. One of our friends were telling that, I think, at that moment. But at that moment, I didn't get that, probably because I am all familiar with the patient. I knew her cancer history and all. Right. So I asked for some investigations, TSH, thyroid profile, ultrasound scan, NIC. TSH was very low with free thyroid T4, which was 7.48, and ultrasound scan NIC shows a diffuse goiter suggestive of thyroiditis. there was no suspicious, there were no suspicious thyroid nodules. And I referred her to an endocrinologist at this moment. And she's now on carbimazole 20 milligrams thrice daily and propranolol to reduce the sympathetic activity. And also, endocrinologist had not done an eye referral. Later, she came back to me with the endocrinologist's records. And the eye referral was not done because thyroid eye disease is very important. I referred to the eye hospital, and she was diagnosed with clinically inactive thyroid eye disease. And she had been started on selenium. And this is to control the progression of eye disease. And also because of the proptosis, the eyelids are not covering the eyes very tightly. So there were the dry eyes. So tear supplements, refresh tears or so on, had been provided. And she had asked to come in another month or so. Right. This is the story. And this is my patient, Mrs. SG now. There's some sort of an improvement, lid retraction and so on. But can you appreciate the thyroid now more than the previous photo? Can you appreciate the thyroid gland is now visible? Right. So, would like to share some points to ponder. I think as a family physician, I followed certain principles of family medicine. Definitely, she didn't go to someone else. She came to me at this moment, at this problem. So it was first contact care and the continuity of care. The patient didn't come just for this to me. She came, she was a regular patient who came for other things as well. And she continuously updated me about her condition, about her treatment. And I also got down her from time to time. So the continuity of care and the coordination of care. I referred her to a surgeon, then to the endocrinologist, then to the eye ophthalmologist. So the coordination of care happened well, but unfortunately, I didn't get a back referral at any moment. I got an update from the eye hospital, but not from the other places. Then what about the preventive care and health promotion? Because the patient was obese. At the first instance, I saw her. I advised her to reduce her weight, and it became a disaster later on, probably. Because then we started, because I did not, probably this had been there for some time, probably even at December as well, but because of her intentional attempt as well to reduce her weight as a good patient, so I didn't notice that. But anyway, that is, I think, health promotion. And also, I think you would appreciate that I recognized red flags, the loss of weight and diarrhea in a patient with a family history and age more than 50 years old. So I referred. But also, friends, I'm just thinking whether did I miss holistic approach to this patient? Because at a point when I was asking for differential diagnosis, you were telling hyperthyroidism as a differential diagnosis, but I could not, it didn't come to my mind at that moment. Did I miss it? You have to answer that. And also a nice thing, thyroid related diseases can have different presentations, crazy presentations probably. Now another story I heard after this. One patient, an elderly male who's a smoker as well, had presented with dysphagia and loss of weight. And you can understand what would be the next step: dysphagia, loss of weight in a smoker who is more than 50 years or so on. This patient had been undergone a endoscopy and all, but could not find anything. And then a CT scan had been done. And from that CT scan, multinodular goiter had been found. And that was again hyperthyroidism. So just to tell you that always remember thyroid disease also. Thyroxine, you know, is a sort of a very important hormone. So it can give rise to many crazy presentations as well. Right. Now the floor is open for discussion. I want to know, did I miss the holistic approach? Or have I acted correctly at this moment?
Yes, Dr. Sankha, this is everything has a reflective learning for the family physician. As you said, is diarrhea and
diarrhea, vomiting,
so
and loss of weight for 2 months duration in a person with a family history of carcinoma and who is elderly as well, say old as.
Yeah, when the complaint is like this, hyperthyroidism must be in a differential diagnosis. But sometimes we reluctant or forget to do the thyroid profile. But this is a good reflect.
Yeah, I also feel the same. I mean, always I would consider hyperthyroidism or thyroid, whatever, thyroid diseases hereafter, because now we are having more experience. But what do you think? Did I act at that moment correctly? Because I thought, because what came to my mind was, at that moment, this patient has a history of carcinoma. She is old. She has altered bowel habits for 2 months with vomiting and loss of weight, a severe loss of weight problem. And when you see the patient, because firstly, when I saw the patient at the first time, 1 year back, she was a fat lady, and when I saw her on this in this March, she has, you know, emaciated massively. So I was like, probably that has also affected me in diagnosing. Any other ideas?
Yes, Sankha, I just want to highlight a key message, that is, even in our patients who are struggling to lose weight and very much committed and dieting and excessively exercising, when you see, I mean, they might think, okay, they might attribute the weight loss to their diet and exercise whatsoever. But as doctors, I think we have to always keep in mind that we have to exclude anything critical in all our patients. I think that is an important key message, because I have seen where even doctors attributing their loss of weight to their dietary practices and commitment to lose weight, and ultimately finding out to have some pathology. So I think that's an important thing as GPs we have to keep in mind.
Thank you, Aruni, for that. Yeah, I also realized that, and I think that's very it's a very important message you gave.
Any other ideas? I think there are some senior general practitioners in the audience and some registrars and senior registrars. So we would like to get their views on this matter.
Sankha, may I interrupt? There's a question from the audience. Maybe you can share your views. How is the fecal occult blood and N2PK being positive explained by with hyperthyroidism? So that is a question coming from the audience.
Yeah, M2PK probably because this diverticular. I think that the diverticular disease probably not disease, diverticulosis probably had some contribution to this. But I'm not sure about fecal occult blood, whether the report is wrong at this crucial moment. Very sad if it was so, because that totally diverted me from something else, thinking about something else. Because the second fecal occult blood was negative. As I told, M2PK is not a gold standard or a diagnostic, but when I went through the literature, it showed that there are about more than 90% positivity in colorectal patients with colorectal cancers. But there can be other false positives as well. And in one of the journals, it was there that one group had written an article telling that this is a very good method. Then a letter to editor has come telling that it's not, and it can be many false positive. But it seems that it's being used. And when I went to it, it has been told that this point of care device or the rapid device is a very good one even for the general practitioners to screen or say have a basic idea about colorectal cancers. But I'm also not sure how to explain this report, but probably whether it's a false report or a wrong report. And
any test?
There's a comment telling that initial obesity might have masked the thyroid enlargement. Exactly. Yes.
And any test can have false positives. So the stool occult blood initially was positive, but then negative. Am I right?
Yes, so yeah.
Maybe because of the increased bowel movements. I don't know. Is there a possibility?
Yes, could be, no? Diarrhea, yeah, there's a sort of a explosive sort of diarrhea, then it could be. Yeah, and when the diverticulosis is also there could have been high chance of having a small bleeds or something like that.
Yeah, in my view, what I would like to share is now, if you go back to the patient's presentation, the HB is also on the lower side. Now, I'm sure this patient is postmenopausal. So, any anemia is a red flag in a postmenopausal woman, because we have to consider colorectal cancer. And also, if I remember correctly, there was microcytosis as well. So it's iron deficiency anemia in the background of a diarrhea. So you have done the exactly correct thing by offering fecal occult blood. But here, what I would like to say is, here now, fecal occult blood is a screening test, and it is well known to have less sensitivity and less specificity. So it is for asymptomatic mass screening, the test recommendation, and you have to do 3 testing. And if 2 out of the 3 is positive, you refer to colorectal cancer, colonoscopy. But in this situation, actually, we do not have to do a fecal occult blood, because anyway, the patient is correct.
Arun, you are not audible.
Not audible at all.
No, now audible.
Sorry. No, in my, what I think, what I'm just sharing my opinion, because now this, you have done the correct thing by recognizing the red flags. That is the loss of weight and also the anemia. And also, if I remember correctly, there was a microcytosis. So it is probably iron deficiency anemia. And in a postmenopausal woman, iron deficiency anemia is an indication for excluding bowel cancers. So that is right. It would be nice if the thyrotoxicosis was considered at the initial differential also, because you could have prevented going for a colonoscopy, which is rather invasive. But on the other hand, even, I mean, we can't say that two pathologies cannot occur within one person. So even if you confirm the diagnosis of thyrotoxicosis at the initial phase, colonoscopy may be justifiable in this situation, because we do have to exclude bowel pathology as well. But on the other hand, what I feel is when the colonoscopy was inconclusive, telling that it is diverticulosis, at that point, we should have seriously taken thyrotoxicosis on board in this patient. So that is how I feel.
Yeah, that's true. Yes, Subun.
Dr. Sankha, can you share the name of the drug you have given the osteoporosis that contain the vitamin D and zinc?
Oh, that is not. I mean, this is that is jointies, Astrans one.
Thank you very much.
It has some. I mean, it doesn't. I'm sure it doesn't have. The reps would come and say that it has. It would grow the cartilage, but that's wrong. It has some analgesic effect. It reduces the pain. I have given this to my mother, and there can be some sort of placebo effect as well, but there were some studies on that. But it has some sort of a reduction in pain, nothing else.
The fecal occult blood 3 samples, is it consecutive 3 days or can it be 3 random occasions?
Aruni, that's your question.
So I'm just referring to the UK recommendations for their colorectal cancer screening program. When the patient is eligible, they can collect 3 containers, and within 1 week or so, they have to give the samples. So I don't think there's a hard and fast rule like 3 consecutive samples, but I mean, it's done one go.
This is for colorectal cancer screening, right? Not for.
That's right. That's right.
At this moment, it doesn't warrant that you have to.
And on the other hand, at any point, if you had the suspicion of an inflammatory bowel disease, was a ESR done or a CRP?
Yeah, ESR was done. ESR was done. CRP actually was not done.
ESR is the test, I suppose.
Yes. ESR was 38.
Yeah.
CRP was not done by me. Anyway, at that moment, what I did was that. Supun, were you asking something?
No, sir. There's a question, why CT with rectal contrast only? Why not triple contrast?
I'm not very familiar with that. Probably.
Do we have any radiology people in the audience? like last time.
We have radiology people, but I don't know whether they are very familiar with CTs. Not they. I saw one. Because the person I saw was from a hospital which doesn't have CT. Probably the surgeon has thought because he has thought of colorectal part only. I'm not sure whether is that the reason. Another question is there, Supun? CA is more sensitive and specific than M2PK. I don't think so. Someone, I don't know. What I know is CA is not so specific. I mean, more, say, later test is M2PK, but still it seems it's also the same. But even CA was not done by the surgeon. This is surgeon and he's a professor also. So I'm not sure about that. I think we can read a bit about that. If someone knows, please explain.
Silence suggests that nobody knows it at the moment, but I'm sure people are searching right now.
I suggest you to read a bit on American Academy of Family Physicians AFP website. Has some good literature on colorectal cancer screening and so on, and also about chronic diarrhea and about this criteria and so on. So just have a look at the AFP website.
Right. So in the absence of any further questions, I just would like to sum up. And indeed, it was a really fantastic presentation, Sankha. It was very stimulating. And finally, I would like to present a keynote for all of us to take home. That is, this is all about continuous professional development. So we have to keep learning. So we have, as a team, we have been able to raise few questions during today's session. That is the two unanswered questions. CT with the rectal contrast, or is triple contrast better for detecting colorectal cancers? And then what is the role of CEA and M2PK? What is superior? And what about what is the place in fecal occult blood? I think there's a lot of reading to be done. And also to keep in mind for any patient who is even attempting to reduce weight by following various diets and exercises and so on, we do have to have an open mind. Is this patient having some pathology in the background? And it could not be the one pathology, maybe multiple. So, and I think as generalists, we have to consider the big picture and concentrate on multiple causes for a single problem. And of course, maybe we do not consider everything on board at the first instance itself, But later on, I mean, we have the greatest advantage as GPs that we have is the continuity of care, as Sankha has shown throughout this case presentation, how he was with the patient throughout. So this is an advantage where with each consultation, we can revisit our DDs and reconsider and reprioritize the problems and get to the correct one and finally help our patients. So thank you very much, Sankha, and thank you very much, Supun, for organizing this fantastic CPD event. And thank you very much for all the participants for making their valuable contribution and participating actively. A very good evening for you all. Thank you.
Thank
Thank you
you.
very much.
Have a safe time ahead.
You too, Supun.